Good evening, everyone. My name is Cynthia Davis, and I'm an assistant professor in the College of Medicine and the College of Science and Health at Charles R. Drew University of Medicine and Science. And I'm going to be serving as your moderator this evening. I want to welcome you tonight to the webinar on COVID-19 and monkeypox. This webinar is part of a series of Bridge Builders Health Education seminars being hosted by the Bridge Builders Foundation. Tonight's webinar is co-sponsored by a number of organizations. The aim of this webinar is to present the most updated information regarding COVID-19 and monkeypox. Before we begin the webinar, I want to introduce Mr. Wesley Shows, Director of the Bridge Builders Foundation Health Education Division. Mr. Scholes.
Thank you, Cynthia. Good evening to the audience who are participating. Thank you so much, Dr. Abraham, for your time this evening. We are happy to have you again. So, without further ado, let me introduce the chairman of our board, Mr. James Breedlove.
Great, thank you, Wes. Well, good evening, everyone. We are excited to bring this valuable healthcare information to our community. We started a few years ago with really trying to get valuable information to our community through trusted resources and make sure that we share this information with our community, through our young people, through our adults, and talk about all areas that disproportionately impact communities of color, and specifically the African American community. Each quarter we partner with regular partners, and I want to share with you our first partner is Charles Drew University. Our second partner is the Links Incorporated, the Palos Verdes chapter, the Cynthia Davis Lifelong Learning Institute for Community Transformation, Tapahani Book Circle, and the Zeta Rho chapter of Omega Psi Phi Fraternity Incorporated. We really embrace the community partnerships, and we appreciate our partners in helping us get this valuable information to the community. So without further ado, I'd like to pass it over to Dr. Jerry Abraham. Thank you so much.
Thank you.
Well, let me introduce you, Jerry. Our guest speaker tonight is Dr. Jerry P. Abraham, Director of Kedron Vaccines, a division of Kedron Community Health Center. I've worked with Dr. Abraham over the past 2 years during CDU's and Kedron's joint community COVID-19 mobilization initiative to vaccinate vulnerable populations of medically underserved populations, and more recently to slow the spread of monkeypox among at-risk populations in LA County. I'm proud to be an integral part of his community outreach healthcare team. In the interest of time, we're asking that you hold your questions during his presentation and place them in the chat box. At the end of his presentation, I will go to the chat box to answer as many questions as possible. There will also be a webinar evaluation form for you to complete in the chat box at the end of the webinar. Without further ado, let me introduce Dr. Jerry P. Abraham. He's muted.
Yes, thank you so much, Professor Davis. Give me one moment to share my screen. All right, just looking at the Bridge Builders website. All righty. Again, thank you so much for having me. My name is Dr. Jerry Abraham, and I'm the Director and Chief Vaccinologist here at Kedron Vaccines in South Los Angeles, where we have been working tirelessly throughout this whole COVID pandemic to ensure that our communities have access to COVID resources, including testing, vaccines, therapies, education, engagement, and long COVID care. Start with our land acknowledgement here in Los Angeles County. We are on the land of the Tongva people, the original owners of this land that became Los Angeles. We honor and respect them and their ancestors and their contributions to this land and all the native and indigenous inhabitants of this community that we're able to live in. And we are all working together to overcome the injustices that are still being experienced by people of color today, including the harms, the health harms of racism. No conflicts of interest. I do not receive any funding from pharmaceutical industry. I'm not being paid to give this talk today. Today, we hope to cover where we are with COVID-19 and with monkeypox, and also just touch on some of the issues related around health equity and how working in health and healthcare, we can be working and striving towards achieving racial justice in our community and society. We here at Kedron are a historically Black institution who partners with Charles R. Drew University, particularly the School of Medicine, a historically Black medical school in our country. And we have worked very hard to prioritize that resources are intentionally earmarked, set aside, allocated for members of the Black and Latino community. And so a lot of our work really focuses on providing care in the Black community. We believe that our work has to be intentional, and you hear it in our passion. You see it with Professor Davis, all of our team members. We're out there and we know we're making a difference, and we know we're doing the work that needs to be done. And for us, it's a no-brainer. That's usually what I have to say when the media asks, Dr. Abraham, why do you guys at Kedron and Drew do what you do? And for me, it's really not a question at all. In fact, it's what do you mean? And I'm usually asking them questions. I'm saying, why is it so hard for you to understand that we have to make sure that people have access to care, and we have to overcome all the challenges, the structural and systemic challenges that are barriers for people having equal access. So that really brought us to this vaccine equity conversation, where we make sure that our communities where we were hardest hit and also often not receiving the resources, we wanted to make sure that the county, the state, and the federal government understood why they have to be prioritized, why our communities, why us, our families, our children, our healthcare workers, they need to be considered in the rollout of any program. So just a little bit about who we are. Our program now has vaccinated shy of 400,000 people. We have tested hundreds of thousands. With our mobile program, we merged with Charles Drew University Street Medicine program with Kedron Mobile, and we have now deployed hundreds of mobile clinics throughout the community. And we've met people where they are, providing vaccines to them in live, work, worship, play, so at churches, housing development, schools, etc. This really is a huge team effort with many members, and it includes a very diverse and inclusive group from all sorts of racial and ethnic backgrounds, but also from various talents and sectors, including from medicine and academia, but also from the public sector, from military, from the faith-based community, community-based organizations, people that work in foreign relations, and all of us that are committed to the health of people living in Los Angeles County. We, as I mentioned, one thing that we did to revolutionize this vaccine rollout was that we knew that the eager beavers were going to come and all grab their shot from these vaccine centers, from Dodgers, from their pharmacies and clinics. But the opportunity that we were missing was meeting people truly where they are, where they live, where they worship, where they work, where they play, where they go to school. And also not forgetting that there's a good number of individuals in our community who, for a lot of reasons, cannot leave home, including those that are aging and ailing, and that they deserve care. They need to be considered, and they definitely should not be left behind as we roll out public health programs. We definitely needed to bring a lot of perspective to the county and government conversations that were happening, especially during the height of the pandemic. First off, are we even in the room? And that was a major concern, because many of the, let's say, wealthier clinics, those in the higher socioeconomic neighborhoods, wider populations received access to the vaccine first, and that was very problematic. So we think of USC, UCLA, Cedars, Kaiser, Dignity. Many of our patients don't access healthcare in those facilities, actually. And so to leave behind Black and Brown physicians and healthcare professionals and their practices really was a big problem. And so even not considering why is Kedra not getting them, or other community organizations, was really a missed opportunity. So as I teach medical students and residents here, I always remind them, if there's not room at the table, we're going to bring our folding chairs and folding tables, and we're going to politely nudge people, and we're going to make our way into those rooms and halls where our lives and our futures are being decided. And we have to remind people that we have to be there, and we need to not only, sometimes I say, no matter how hard we try, not everybody's going to be able to get in the room. So when we're in the room, are we using our power? Are we using our voice to really stand up and advocate, especially for the least amongst us, those that can't be in this room, and speak up? And so that's just something I charge every one of you to have that passion. In many ways is the heart of what we do as healthcare workers, caring and serving for people. We had to do a lot of things in order for people to understand the pandemic from a health equity and a racial justice perspective. When we looked at the data and looked at the neighborhoods hardest hit, that's not necessarily where the vaccines went. And so we piloted programs and definitely pushed the envelope and probably made several people upset. But we said, if you're from the zip codes hardest hit, we were going to allow you first priority for these vaccines. We had piloted a strategy where if you had a household that had COVID, then you should get first dibs at these vaccines. We made sure that our site was a walk-up site. We made sure that, if you couldn't see, hear, walk, talk, that you can get these vaccines. And we had innovative strategies, including, they created that funky registration system, including my turn, that, really stood in between grandma and her vaccine. And so we really felt like we'd created digital fortresses, and there were digital demons that were keeping people away from the care and the treatment, in this case, the life-saving essential medicine, these vaccines. So we created paper registration forms that helped, and made sure that we reached people in the language that they needed to be reached out to, including for our community. We need to make sure that we're speaking the language and appropriately, culturally, responsively, and that's something we prioritize here. A lot of what we did in the beginning too was to really make sure that we were focusing on education and engagement, especially because knowing our history and the medicalization of racism in the system, knowing that Black men were denied treatment of syphilis with the Tuskegee trial, and knowing that Henrietta Lacks cells were abused and her family never received any recognition or compensation for the use and abuse of her cells, which helped develop many treatments and diagnostic approaches that we use today in medicine. We know that many Latinas were sterilized within the LA County system. We know that there is an under-treatment of Black pain in our hospitals and clinics, and that's a major issue. And we continue to work to address all of those issues. And so we really needed to make sure that we acknowledge that, just as we did the land acknowledgement, we acknowledge the past of lived and people that have gone now, and recognize these are real, and that people are still suffering from those events. And if we did not start there, then we really were doing a disservice to the context as to why, when we approach the Black and Latino community with these public health interventions, we may be met with distrust or misgivings, or as they like to call it, hesitancy. But the truth is, at the end of the day, what we wanted to make clear to everyone was, Black folk wanted these vaccines just as much as everyone else. In fact, what we were more concerned with was, where was I supposed to get it? Was I offered a vaccine? Those were kind of the bigger challenges and questions we needed to answer critically. And instead, you saw how quickly, the media can misconstrue and misportray and say Black and Latino hesitancy was very high compared to other communities. And so little by little, we have to do all of this education, really rewrite these narratives and make sure people understand, what really is going on, especially in the middle of a crisis. In our program, we're fundamentally, keen on making sure that we treat people like people. And part of that is meeting people where they are. And it's really recognizing the dignity and worth of every human being and respecting them for that. And so that's really the recognition of their humanity. And we definitely, throughout this whole process of vaccinating, believed in this mantra of engaging, educating, vaccinating, and activating. And because of that last piece, activating, so many people, including I'm sure on this call alone, were activated to go and get their church members, their coworkers, their family members, their classmates vaccinated. And so because of that, we've really made a lot of gains. And so throughout this whole emergency, there's been a lot of innovation, including, bringing treatments to, reality, expanding upon testing resources. A lot of research has happened, and we wanted to also make sure that Black and Latino individuals were part of the clinical trials and also part of research studies to make sure that we answer firmly that these are not experiments on our people, and in fact, are so we can resoundingly say are truly for everyone. So where are we right now with the pandemic? Now almost over 500 million people have had COVID-19. We have had 93 million cases here in the US, and our country of 330 million plus people. So imagine just several, honestly, these are all underreporting, right? So we believe even more than half of the country has had COVID, to be honest. We believe there was at least documented over almost 11 million cases in California, and we're approaching 4 million cases here in Los Angeles County. What we also saw was definitely the disparities in access. So as we saw, the Black vaccination rates lagged white and Latino rates, but we saw that Latino men died at 3 times the rates of white people, and Black men died at 2 times the rates. And so there was really a disconnect between who was receiving the care, who was receiving public health, and then who was actually having these adverse outcomes. And yet we know it's not for any biological reason or having any sort of different body or anatomy, but truly a racist system that kills people disproportionately based on the color of their skin. And so that's really important as we look a lot of the data and as we sit with the county and we really look, and many people, including I know Dr. Solomon's on the call, and Black vaccination, Black Vax, that campaign. There are several groups, Black Women for Health and the California Black Health Network, Black Health Trust, Minority Health Institute, that all made sure that they, sounded these alarms, that we looked at more critical, with a more critical lens of the data, and that they really parsed it out by race, ethnicity, by age, by sex, by gender, to really understand where the disparities lie so that we can be much more focused in our approaches. And that's how we came up with so many of the solutions that we've employed and many others, including going to, barbershops, salons, going to churches, really being in the community where people are, including, partnering with Divine Nine and several of the Greek organizations, making sure that, we really are present. And that is important, that we're not just showing up when we need you to do something. We need to be present and we need to be available so that we can meet people where they are and meet their needs. And that's really important. And that's a lesson I hope all of us in healthcare take back, as I always share in these conversations, is that it would be only criminal if we go back to the way things were. And so as quote unquote, we go post-pandemic and we learn to live with COVID, we really have to remind people we're not going back to the way things were. Because that way kills people, including most specifically, kills our community disproportionately. So the fight is still going on. The fight is real. And the truth is that our children have not gotten the COVID vaccine. And so please, if there are concerns, let us know. Let us help you answer those questions. We want to make sure that our children are safe, especially as they're back to school. And as we approach the fall and winter, we anticipate another spike in COVID cases. And so we'd really want to make sure that all of our children have access. And now people over 6 months and older have access with Moderna and Pfizer, and there's still Johnson & Johnson available and Novavax. We have more and more tools in our toolkit and less reasons not to get vaccinated. We're still working very hard to get these boosters out. As you may have heard, the Omicron booster shot came out, and both Pfizer and Moderna are available for that. And that provides us additional coverage, not only for the more original strains and Delta, but also for the Omicron strains of COVID-19 that protects us. And that strain is more infectious and spreads more easily. And so this really helps protect and guard us from serious illness, hospitalizations, and death. And that's really at the heart of these vaccine programs. And we still continue with the equity journey as the numbers are still lagging where we want them to be, equal or above. And so that is the work that we continue in the Black and Latino community. So now where do we go from COVID-19? That really is, I think, part of the question. And we'll get into that in a minute. But first, we were hit with another public health emergency. That was the monkeypox infection. And that was a very rare disease that was indigenous to Central and West Africa, primarily a disease that affected children and pregnant mothers. Often kids would go play in the bush, in the jungle, playing with mammals, rodents. Imagine just all the types of mammals that are running through the forest. And so monkeypox is actually a disease. It's a misnomer, actually. That's why we write MPX instead. There's a lot of issues with the word monkey, and not only the racist issues there, but also we've seen, attributing this to a monkey spread disease, and it's not. It's actually common to many mammal species. And so when kids go out into the bush, they touch, they hug, they play with these animals, then they go and hug, mama and her belly. And so that's where they would get all the pox, the rash on the kid's hands and face and on mama's belly. And in Africa, it's actually 30% fatal. It's a big part of why we took it very seriously in the beginning. Around the world, there were tens of thousands of cases. The US, it exploded here and became the country with the most diagnosed cases. And we ended up with one fatality here in LA County and actually over 1,000 cases now in Los Angeles. But the same challenges we saw with COVID existed with monkeypox, where the rates were highest among Black and Latino men. And so that was something we really had to understand and address and figure out why Black and Latino people are not having access to the monkeypox vaccines and all the interventions, including treatment that is available. There is a treatment called TPOXX, tecovirimat, that is an antiviral. Again, when you look at who gets these treatments, who gets vaccines, it's a real, there's real disparities there, and it's very troubling and concerning. And so we've got to figure out how we change that moving forward, because we know that as a result, people disproportionately suffered, and in this case, Black and brown men disproportionately suffered from monkeypox. But there was hope, and we learned a lot, and we did a lot of good things with the monkeypox pandemic. And so we were really able to change people's behaviors, and it spread within specific communities. In this case, there were communities, LGBTQ communities, and men who have sex with men, and really changing some of those behaviors. In addition, so different isolation and quarantine practices, really encouraging testing anytime there were lesions that we were worried about, rashes that we were worried about. We really prioritized getting that vaccine out, and even saw they had changed the dosing so that we can really ration and provide more vaccines to more people. And because of all of that, we definitely now today see a decrease in the cases and overall a leveling off, and we hope that it stays that way. But the concern, of course, is that if it becomes endemic, just as I mentioned, those mammals running around, if it gets into rodents, cats and dogs, then it's kind of here to stay. And if that's the case, then we need to make sure everyone gets vaccinated from monkeypox. And that's still yet to be determined, but those are the types of considerations we need to make in public health. And so you're following the science, you're following the facts. And as you do that, of course, your recommendations change. And then how do you apply that to actually rolling out and providing these programs to a whole population, a whole people, a whole public, and then knowing that not all care is equal. And so how do you address all of that with also an health equity and a racial justice lens is really important. It is exhausting, and sounds like a lot, and it is, but that is the work that we have to do. And there's a price and a toll associated with that, but that is the reality, and that's important. So we understand there are lots of challenges both structurally, institutionally, within the system. We also know there are lots of social determinants that disproportionately affect communities of color and also socioeconomically disadvantaged communities. When we look at housing insecurity, food insecurity, when we talked about monkeypox, there were people in the sex trade or transactional sex. Imagine having to do these things just to have a roof over your head, or to put food in your mouth, or to feed your families, or in some cases to feed addiction. So when we think about substance use, IV drug use, it's all very much so connected, not only to higher COVID rates, but also higher HIV rates. As we know, Professor Davis, her lifelong work has been, within the HIV space, and we understand the role that drug use, specifically IV drug use, how they're all connected, and then that's connected to hepatitis C and other infections. We know that then these individuals are the ones that are most likely to not have access to care. They're underinsured, uninsured. And so what do we do about that? There are health literacy challenges. And then when they do seek care, when our patients do seek care, those that are most minoritized, marginalized, and how can I say, with the issues that we're talking about here, whether it's severe mental illness, substance use addiction, homelessness, we're putting a lot on them to have to seek out. And then when they do, being met with medical racism or further traumas, you can only imagine why we see the outcomes that we see. So very cyclical as to why we have the current state of health affairs that we have, particularly within urban meccas and within places where we work, and understanding how do we break these cycles is critical. So it's really addressing these social determinants, which is why we believe housing is health. We believe food is medicine. It's why we have to move more and focus on our physical activity. It's why we need to make sure our children are getting good educations. And then we know that economic empowerment is critical so that people can break these cycles. And I do a lot of work in climate change as well, and we look at health equity and racial justice. And another example is redlining, and you see the challenges in being able to pass generational wealth to descendants, particularly in the Black and Latino community, but specifically in the Black community, with policies that made it next to impossible to buy any land or property. And so people are able to pass those on, especially when you look at people in the white community, just seeing how that wealth gets passed from generation to generation. So how do we break that? And then how do we empower our communities so that we're able to pass on generational wealth and health and knowledge, and then really be able to rise up against some of these barriers that we have been oppressed by. And so there's a lot of work still happening, even when I mentioned the example of climate change, not only redlining, but we know that our communities will be most disproportionately affected by things like climate change. So as we move from COVID, as we deal with monkeypox, there are lots of alarming public health issues on the radar that we need to be prepared to address. And so climate change is another example where, for example, with extreme temperatures and heat, there are plenty of people in Los Angeles who do not have air conditioning in their homes. There are people in Los Angeles who do not have necessarily always an elevator or be able to move up and down floors. Imagine if you're 65 and older, imagine you're one of our elders, our beloved grandmas and grandpas who have mobility challenges and medication challenges. And on top of that, to deal with extreme heat, there are lives lost because of these issues, as you saw in Florida with Hurricane Ian, over 100 plus deaths due to that flood and hurricane event. You see the torment and carnage in Puerto Rico, and you see that our climate futures are tied to our energy futures. And what future do we have if we can't, go to work, go to school, live our best life, live our highest quality lives? And so there's still a lot that needs to happen. And it's not just here domestically. We know these disproportionately, affect low income and middle income countries, and yet they're often not the greatest polluters or contributors to carbon emissions. So those are the types of things that we have to get our governments, we have to get wealthy countries, we have to get those with resources to prioritize. And that's a lot of the space that you'll see public health advocates, health policy advocates working in. Do we have the evidence base? Can we make the right argument? Can we make the compelling narrative and really telling people stories, including you guys on this call right here, about how all of these things impact us, impact our lives, whether it's the pandemic, whether it's monkeypox, whether it's climate change, whether it's all the things that we face in public health. So what has caused this divide? We'd already talked about some structural issues. We've talked about the economic forces. We've talked about, underinsurance, even of our homes and of our properties, the challenges when it comes to employment, with histories of incarceration. What is that? What harm does that do for people being able to be economically independent and also to be able to live their best or healthiest life? So those all have to get addressed, including reform of the correctional system to make sure that people, especially within our community, are not locked up, especially for nonviolent crimes and for offenses that people in other communities commit but never face the wrath or the full extent of the law for. And those are the types of barriers that we see when it comes to inconsistent policing and inconsistent enforcement of the law that I know that justice advocates and others are working so tirelessly in, but do clearly affect people's health. And that's why we engage in that work, because all of this is health. Many times they say, Doc, why are you getting involved in all this work? It seems so like outside of your lane. This is not medicine. This is not public health. And yet the truth is it is, because all of those things that are traditionally not health, education, economics, housing, food, these are actually very much so tied to whether or not we will live long lives, healthy lives, high quality lives. And so we really need to do a better job of understanding that. We need to do a better job of informing one another, the power that we have in voting, the power that we have in electing leaders who understand that, or who are from our communities, who can then change the structures, the processes that are continuing to oppress within our system. So we've been using a lot of what we've learned, and we hope that will continue to inform our process. And so now we're really turning to this mobile street medicine model where we're learning to live with COVID, and it's a post-pandemic world, even though I'm sure we're going to have lots of cases this fall and this winter as we move into cough, cold, flu, pneumonia, and now COVID-19 season. We may be getting booster shots every year along with our flu shots. So that's going to be in the background, and we're going to have to continue to do that in addition to all of the things that we need to do. Sorry, I was looking for a set of slides that I wanted to cover in terms of the role of masking and the controversies around that, in addition to looking to access to testing. As they commercialize vaccines, as they commercialize testing, you better believe that lower socioeconomic communities, communities where you may not have the same distribution of retail pharmacies or grocery stores, are not going to have the same access to testing, to vaccines, to therapies. And so that's of grave concern as the federal government stops providing resources for COVID-19. So that's going to continue in our work. But we've known now that a lot of things haven't happened because of the pandemic. We know people have not been getting their mental health care that they've needed. And there's a silent killer and pandemic that happened during COVID, and that's of depression and anxiety and suicidality and substance use and alcohol use. So all of those pieces we need to pick up. Can we somehow transform this vehicle, this metaphorical and literal vehicle, to address things like substance use and alcohol use and mental health? We want to see what can we do within this framework that we're building between Charles Drew University and Kedron. Is there a way for us to improve Black maternal mortality and to also improve outcomes for newborns? And there's like a lot of programming and research that's happening in that space. We want to look at what else we can tackle, including reducing violence, particularly gun violence. And then we wanted to look at all of the epidemics that have been in the background that people have been working on, but that have ticked up because of changes in behaviors, isolation, riskier practices that may have happened during the pandemic when people were very desperate and really at the end of their rope. So things like HIV, increases in HIV rates, increases in all STDs, gonorrhea, chlamydia. We have really high rates of syphilis right now, untreated. People don't even know that they have these infections. We've really got to do a better job. And that's something that we look at. How do we bring along those services in this program? How do we treat people for viral hepatitis? How many folks are living this world never even knowing they have hepatitis. They've never been tested. They've never been properly cared for so that they can get the proper treatment. And these, again, are all now treatable. These are preventable. So it really doesn't have to happen. And that's the truth of COVID-19 too, as we think about, back in the early days. Okay, so people died and a lot of people died. But once we figured out what was happening, once we had vaccines, truly these were all avoidable and these are preventable. And so that's where we got to really start thinking about prevention and how do we screen better, including for things like cancer and chronic diseases. We talk about diabetes and hypertension and cholesterol. We need to do a better job of providing care to everyone in our community. And the last piece I was going to mention was when it comes to COVID-19, there's a lot of work happening around therapies. And so we know that disproportionately our community doesn't use things like Paxlovid, Molnupiravir, Evusheld. These are all treatments that are available and people use all the time, but maybe not in our community. Where do you get them? How do you access them? What are they? I didn't even know they existed. So we still have a long way to go in providing that education, engagement, being present. And that's part of what we do with our program is that one-stop COVID shop, to be able to answer everybody's needs and concerns. So that's kind of where we are with our program, but there's a bigger conversation clearly happening. And I know that we've got to figure out how we can continue to prioritize investment as well as resources, human capital, and also structurally, how will they be integrated into our institutions, our medical schools, our hospitals, our clinics, to make sure that we have a lens on addressing disparities that have disproportionately affected people in the Black community. And so those are things that I know are the conversations that will continue to happen. The race is not over. It is not won. It is not a sprint. It's not just a marathon. It truly is this relay race. And we're going to be running for a while, but we're running in the right direction. That's the hope that I want everybody to leave with, and to know that we all play our part. We all are part of the solution. I want to empower each of you. Get vaccinated, take care of yourself, do your COVID care, take care of your families. Think about the role you have in improving the lives of people in your church or in your school or in your workplace. There's so much that we can do to advocate. We talked about even as simple as voter registration and how that impacts health and all things that we've talked about today. So definitely leave here today with something that you're going to do, or one extra activity or action that you can engage in that will help move the dial that much closer to achieve the equity and the justice that we all hope and believe in. So with that, I'll go ahead and turn it back over to Professor Davis for questions and answers. Please stay in touch. We are so thankful for the opportunity to be with you all, and we really are, especially as we watch the situation right now. I meant to start with this, the situation that we see with the city council. This is so not just words on a slide. As I teach students, these are not, theories in a laboratory, not words on a page, but literally we're living this right now. And so I use that word, we talked about monkeypox and the implications. So hearing that, there are people that use that kind of language to describe people in our community, knowing the way people talk and knowing that these are leaders. So what are we going to do? And so definitely demanding justice, demanding accountability. And we hope that our city and our county continues to heal. And I know we're going to need a lot of that. I know there's a lot of prayer and a lot of coming together happening today and as we move forward from these events. And so definitely want to recognize that and the trauma it's inflicting and the pain, and that that is suffering. And so what are we doing to address that? So with that, I'll turn it back over to Professor Davis. Thank you.
Thank you, Dr. Abraham. Very well said. I'm going to go to the chat box and see if there are any questions in here. I see there's one from Mr. Breedlove. He's asking, what can community-based organizations do to assist in reducing the social determinants of health? And is the need greater for advocacy or education or both?
Great question. Thank you so much, Mr. Breedlove, for that. And I will say it's definitely all of it. And it's so important that community-based organizations are a part of this work, of this solution, that they are prioritized, that we legislate and we make sure we allocate funds within the state and county budgets for CBO work. And I'll also add in there faith-based organizations. We know the church does a lot of public health and healthcare related work. And so that's first and foremost, recognizing that CBOs and FBOs play a very important role. Something we always talk about is that all people are actually a part of the care, the health team. That includes teachers, that includes pastors and church members, that includes coaches, civic leaders, community leaders. Sometimes while doctors and nurses may be one of the most trusted voices in society, we're not always the most effective voice. Sometimes it's coming from grandma or your auntie that might make you go get that issue checked out in the hospital or the clinic, or you might go get your cancer screening because your wife says you need to go get that colon cancer screening because there's colon cancer in our community, or we need to go and make sure our blood pressures are measured and checked. And so just remember how important that we live, not in a doctor's office, not in a cold, sterile exam room where I am right now, right? We're not living in hospitals, we're living out in the community. So that's why it's so important that we recognize that community-based organizations will play a critical role. And so know that you're a part of the health team. And so what does that mean? I would say CBOs need to continue to be a part of testing. We need to make sure there are grants available so that you all can continue to provide free testing to the community for COVID. And we need to add things like HIV testing and STD testing. That's all going to be very important. We need to make sure that CBOs can receive grants for hosting health clinics, vaccination clinics. We would love to see more screening, prevention, even primary care mental visits happening at CBOs and at churches and other houses of worship within our community. And so that's going to require intentional priority setting for how we use public dollars. And so I think that's something that we need to continue to advocate. Trying to see if there's anything else. Of course, the advocacy piece we talked about. Of course, the education we talked a lot about throughout the pandemic, town halls, and the role, trusted messengers. So if I hear it from someone I trust, whether it's my pastor or a club that I'm in, someone I respect, maybe a leader in that organization, they say I got vaccinated, or they host an event where we can get our questions answered, people are going to feel more comfortable. And I want people to know that it's while we deal with all of the issues truly of racism, we also know that the healthcare experience is cold and lacks human touch and empathy and kindness. And so it is normal to feel afraid of hearing a diagnosis, to feel afraid of what will that test or diagnostic do or mean for me and my family. And so we need to figure out better ways to help alleviate and help people navigate through that and let them know they're not alone and that they have a more humane experience through this whole healthcare system that really is stacked against us, that doesn't make any sense, that steamrolls over people and results in many casualties. So there's still a long way to go, but I have no doubt answer. CBOs and faith-based organizations are going to be a very important part. They're going to become more important, and they're a critical piece in the work that we do with our mobile street medicine program.
I have a question, Dr. Abraham. I guess it will be in December that we've had access to the COVID-19 vaccines for about 2 years. So from the data that you've seen or you're aware of, have we at a national level and at a local level in LA County, have we reached herd immunity? Because I believe Dr. Fauci was on TV last week to say not to get complacent, and that there could be the potential of another virulent strain that appears this winter that the vaccines might not be effective against. But if we reach herd immunity, do we have much to worry about?
Yeah, great question. And you saw the numbers that we presented earlier. there's a debate out there. Have we achieved that natural and induced immunity so that we had this herd immunity where 70 to 90% of the population has some form of protection coverage? And that's really what we do with measles, mumps, rubella, for example, those childhood vaccinations. When we had that herd immunity, measles cases were unheard of. But because the vaccination rates continue to decline, we're seeing more and more outbreaks of things like measles. So absolutely, as our natural and induced immunity wanes, and also as less people just get vaccines or get the care they need, we might and will see increases. So that's something to definitely keep in mind. One of the challenges with COVID, so the flu mutates and evolves very rapidly. COVID does as well. So while we're building up our tools, our arsenal, our strategies, including therapeutics and vaccines, the virus keeps mutating. And so one nice thing has been that it has been more and more mild, like the common cold is mild, right? So COVID's not the common cold, but if we can get to a place where people don't have to be hospitalized or don't die from COVID, that's important. What I have to remind people, though, is that even the common cold or the flu or pneumonia kills aging and ailing people. When we think about patients that are immunocompromised, immunosuppressed, people that are on chemotherapy, for example, people living in nursing homes, they're very vulnerable. So yes, while COVID becomes more mild as we anticipate, will there be a new strain? Yet to see. Cases are rising in Europe. We're seeing increased cases in England right now. We're not saying there's a new strain yet, but that's the type of thing we'd be worried about as we see a rapid rise. Will there be a new mutation? If that happens, yes, some of the vaccines we've received may not be as effective, but they still protect you from serious illness and death. And as I remind folks, you don't just get vaccinated for yourself. You're really doing it out of loving kindness for each other. You're really doing it to protect grandma and grandpa and all those that are ailing and those that cannot get vaccinated. That's really who and why we have to get vaccinated, so we can protect one another. And I think we don't always message that well. And that really is the difference between medicine and public health, that these strategies really are about improving the health of everyone in the community. And so we need to continue to use these strategies. And I think, to your question, Professor Davis, we may continue to debate the use of masks as we move into this period. I think we're going to have to dial it up and dial it down as the numbers go up and down. And that's the reality. I get asked by pastors all the time, should we have choir practice? Is it okay to, sit closer to one another? Is it okay to ease all the restrictions or not, check test or vaccine status? I mean, these are hard questions to answer for your organizations, for all the places that we go. But they're ones that we're going to continue to grapple with. And so I would say we need to remain vigilant and ready. Something that Professor Davis knows that I talk about in our team is pandemic readiness, pandemic preparedness, because we shouldn't be blindsided. We clearly were with COVID, but now if there's a really serious strain or some new event that happens with this pandemic, we really need to be ready to dial up our strategies and to really be able to make sure that the fallout, that the casualties, that the damage is very minimal. And that's what I hope to do going forward. I wish I had a more specific answer, and I wish I had a crystal ball, but it really goes to show us that, we don't know. Many of us are people of faith. We will definitely, move forward, do what we have to do, but then also have faith that we will do all the right things to save as many people. And we kind of move forward with that kind of hope, if that makes any sense.
Thank you. Wesley, I see your hand is up.
Yes, thank you. This is an extension of the question that Jim Breedlove asked Dr. Abraham in terms of what can organizations like ours do to sort of meet the objective. Keep in mind that we have a cohort of, I think, at least 500 young people that we constantly communicate with. And my system just dropped for a second. So keep that in mind. And we work very closely with with Cynthia and her operation as you do. So consider us a resource that you can always come to help you get your message out.
Thank you so much for that, Wesley. I will say there's still so much work to be done, and I know that y'all are doing a lot of work in the schools and with our youth. And so one thing that I know that our groups, including Bridge Builders, can definitely focus on is encouraging students to continue to pursue academic excellence, to really pursue their dreams. We have such a shortage of health workers. We really want people to consider choosing health careers in public health, in medicine, in nursing, in all sorts of health professions. We need everyone, and we need the workforce to reflect the demographics of the communities that we serve. And that's still been a really significant challenge, especially coming from historically Black medical school, where that is so much of our focus. We're struggling to, fill our schools with bright minds that want to go into healthcare. And we know that people are burning out. The healthcare workforce is leaving. People are retiring early. People are, just so frustrated or exploited, burned out, morally injured. And so we're going to have to figure out better ways to bring more people to the health system, because as we all age and as the baby boomers continue to age, we're not going to have a health workforce that can meet those needs. And so if we can encourage people to choose these health careers, which does mean we're going to have to prioritize, as y'all mentioned, the STEM activities, science and technology, engineering, mathematics, they're going to be critical for anyone choosing careers in health. And those are areas that you guys are really able to help and provide that resource and support. And that's something that I hope you consider us at Charles Drew University, at hospitals and clinics like Kedron. We want to be able to mentor, to really provide that type of support or educational programming and assistance, so that people have all the tools to be successful if they choose to join us in healthcare.
If I could just make one minor extension to that, in that regard, one of the series that we have operates under the theme of what you see, you can be. And I believe it's December 9th. On that particular session, the subject will be careers in public health. And Cynthia has graciously agreed to handle that session. And as luck would have it, just within the last couple of days, I reestablished contact with a young man who at the time was in pre-med. And I learned that he is now a senior manager in the U.S. Public Health Service. And he has agreed to join that session. So we'll be able to talk about careers in public health from the local and state perspective. But as you certainly know, the U.S. Public Health Service is a tremendously large organization. So we'd be happy to see a Black male in a senior executive position with the U.S. Public Health Service.
We have two more questions before we close out. And this one is from Mr. Breedlove. Are there any emerging strategies or best practices in addressing medical racism? We often hear about equity and access, but there's a lot of, hesitance because of distrust in the medical field. How is messaging working to reduce those concerns?
Yeah, that's a great question. I'm dropping, I think, okay, well, I'll send this to the host and panelists, but we can share this further. There's a film that's coming out, Color of Care, that really talks about these disproportionate, access and substandard care. And there's clearly a lot that we can do to address head-on medical racism. Some of it will be the internal work that needs to happen, introspection, and I can share all of these resources with you after. We can send them out. The American Medical Association has done a lot of looking into this. They created a narrative guide with all of the language that is a part of the conversation. We talk about addressing racial and ethnic disparities in our communities, and also what does it mean to not only own these pasts, and then how do they correct moving forward, and what can we demand from organizations like the AMA and from institutions that have created so much harm. I think those are very important conversations that are happening, and there's a lot of literature around strategies that work. So definitely we have to know what our own biases are, those implicit biases. We need to do the work both personally, internally, but also within our organizations. Where does it hide, and how do we shine light on it and stamp it out? And then we must be able to figure out how do we join forces externally to make sure we're building the right coalitions and the right movement campaign so that we can advocate. And ultimately, it does require resources. It does require prioritization within our budgets, within the how we use our tax dollars. All of that is going to be a part of how we address medical racism. But I will say, on the personal level, always feel empowered to stop and ask and say, I would like to speak to someone else, or this, something's not right here. We really need people to feel that they can and should, expect better care. And I think that's going to be important, but it's hard to place that burden on patients, especially as they're ailing. So I do ask, please be navigators for your loved ones as they interact with the health system. We've seen all too often how many missed cancers, people not treated equally. There was the case of the pregnant woman who gave birth at Cedars, who died from bleeding out, even though she knew something was wrong, her husband knew something was wrong, and yet nothing happened. And so that's literally happening right now and today. So we definitely have to call that out. We definitely have to ask, for better services, or demand often is what I say, and then make sure that we are able to look out for one another, because the system is so deadly, truthfully, right? The healthcare system, and yet we need it to survive. Often we're dependent on these life and death interventions and measures that we offer in healthcare. So it's like a necessary, don't even want to use the word evil, but the truth is there's a lot of things that we need in healthcare so we can live and live healthy lives. But there's so much that shouldn't exist in the system, and we've got to figure out ways to rid healthcare of that, of those biases. And so hopefully that helps answer the question. There's no easy answer. There are a lot of resources. I am not the authority on this. I am not the, I am someone who's a part of the conversation. I'll say, all of us are having these conversations and growing. I struggle to even think that there's the word expert in this field, because the truth is we are all in this together, and we're figuring it out. And we have something to learn even from, as I remind our community members, you don't have to be a doctor or have a PhD to contribute something meaningful, to contribute perspective. Patients contribute so much, community members contribute so much, and you have something to share. And we don't call you an expert, we should. We all have something important to contribute to this conversation. And I think if we approach this medical racism in this fashion, I think we'll be able to make more progress.
There's another question from Dr. Olga Solomon. She says, how do we come together to better serve people with disabilities, including those with intellectual and developmental disabilities, so they receive equitable health care for the COVID and monkeypox related concerns, but also for all the other concerns such as cancer, diabetes, hypertension?
Yeah, we still have not fully figured out how to deliver care. It's interesting because we can order food, directly to your home, Uber Eats, Postmates, Grubhub. We get all of our things delivered and shipped to us, Amazon, you're seeing Walmart, everybody's entering the space. But we haven't been able to really figure out how do we deliver care well for people who live, work, and play. And that's why I do believe often that we're on the front lines and being very innovative with our mobile street medicine program. And that really is how we can better serve those with physical and mental disabilities and limitations, those with developmental disorders and cognitive disorders, learning disorders. Many of these folks are not able to access healthcare in the traditional sense. And so really figuring out ways to remove all those barriers. And for us, we have definitely seen the value and the impact of being able to go directly to people in their homes or in the schools where they are. And that has really reduced some of the challenges that families face in trying to get, a nonverbal, perhaps even extremely aggressive, severely autistic patient who still also needs a vaccine. And how do you get that to them and get it to them safely, and also making sure the care team is safe and also not injured? These are all very challenging spaces to go into, Dr. Solomon, as you know, but it's one that, as also we work closely with regional centers, group homes, recovery homes. I mean, that's exactly the type of work, and it's really it's important work, critical work, and I know in some, for our team members, many leave transformed or feeling that they are making a difference in people's lives. And I say that because so many people are so disillusioned right now and frustrated with what they do in healthcare. But so often our team, we're out there in the community, and you're getting to have those conversations with real people and see the difference you make right then and there. And that's also transformative for the healthcare workforce to know and to bring joy back to our work. But to your point, we still have to do a long way to go to reach people that can't even access care in the current system, including those with developmental disorders and other disabilities. And more of what we're building is what I hope. More funding for these types of programs is ultimately what I hope. And I hope every one of you, everyone on this call, ourselves included, can pick up our phone one day and look at an app and be able to have healthcare and public health on demand delivered directly to you wherever you are.
The last question, I'm going to read that, but while I do it, William, could you put the evaluation survey in the chat box for everybody before people start logging off?
Absolutely.
Thank you. So the last question is from T. Dowdy. I appreciate you stating that you are a person of faith. Do you feel if more health professional people like yourself would be willing to admit they are a person of faith, would get more people to accept faith and science to get vaccinated?
Yes, I talk about this a lot. Maybe, I'm not sure if anyone on this call has been to any of the sessions where we've talked about faith and healing and how we can be people of faith and people of science. I believe that God made us, God made men and women, and then we were able to become doctors and health professionals, and men and women made medicine and health interventions. And so I truly believe these are divine. I believe that these are miracles, and we really have these miracles and tools. And I remind, I think these are the stories, and we have to be more open, and I share them with my patients. I have prayed with patients, honestly, if it's invited and it's the appropriate time and place. We know that there's power in faith, there's power in prayer, there's power in that in spiritual healing for the physical body. And so I think it's very important that we recognize that, we invite that into our space. I do mention to people of faith, we don't want to get there and St. Peter or St. Paul say, why did you come visit us any earlier than you ought to? I gave you those tools. I really provided you the resources. And so we don't want to go any earlier than we ought to. And that was something important when we talk to church communities, the faith-based communities. God has given us these tools, and we need to use them so we can live the divine lives and live the mission that we're supposed to, live out the faith and live out that full life. I think that's really important to tie those together. I also mentioned, as a person of faith, so much of what we've done has been a miracle. When we think of the miracle, it felt like Noah's Ark. Get on board. The floods were coming. We needed to get everyone vaccinated. We felt that we would never have enough vaccines. It felt like the miracle of loaves and fishes, trying to feed the multitudes for us, vaccinate the multitudes. It's so often it has felt desperate and dire, and turning to faith, turning to scripture has been nothing short of helpful, and honestly praying and having faith. So I always remind people Absolutely. These are shots of faith, and these are opportunities to talk about our whole selves, including our spiritual selves. And that's really important. So I really appreciate recognizing that. Thank you for that. I hope and we encourage more health professionals, because that is true. That is a part of who we are. Why are we denying that? And for many, many of our patients, that's going to be a very important part of their healing process.
Okay, well, thank you, Dr. Abraham, for a wonderful presentation. I look forward to seeing you out in the field. I want to thank the bridge builders for all that you do to improve the overall quality of life of our community. And if Mr. Breedlove has any closing remarks, I'm going to turn it over to you, James.
Oh, thank you, Dr. Davis. No, I just, Dr. Abrahams, I want to definitely say, wow, what an awesome presentation. I certainly appreciate the candid and open discussion and dialogue about, health disparities and the consequences in our community. And I just want to thank everybody for coming. Just looking forward to getting out there and doing what we can to assist our community in these, very necessary areas. So again, thank everybody, and look forward to seeing you during our next session. Thank you so much.
Okay, good night, everyone. Don't forget to fill out the survey, the evaluation survey. Good night.